recertification. These are my disclosures. The goal of this talk is not to cover all spine surgery. It's to cover the most commonly asked questions and concepts and provide some high-yield facts. We're going to cover biomechanics and basic science, spinal trauma, spinal cord injury and associated syndromes, degenerative conditions, spinal infections, and spinal deformity. Basic biomechanics. It's important to remember that the body weight line lies anterior to the spinal column. Therefore, the vertebral bodies act as anterior column support, and the posterior elements act as a tension band. This helps maintain sagittal balance. Therefore, if you lose anterior column support, you fall into junctional kyphosis. If you lose the posterior tension band, you fall into junctional kyphosis. In this illustration here, we have a patient who has a burst fracture who's lost anterior column support as well as the posterior ligamentous complex. As a result, the reconstruction involves restoring the anterior column and pedicle screw and rod fixation to restore the posterior tension band. Let's also look at the uninstrumented cervical spine. We realize that with the strut graft in axial compression, the strut is stable. In flexion, because the axis of rotation is posteriorly at the facet joint, the strut graft will be in compression. However, under extension, it will unload the graft and make it relatively unstable. What happens if you add a cervical plate? In this model with the instrumented cervical spine, it rotates the axis of rotation anteriorly to the plate. As a result, during extension, rather than unloading the graft, it results as a nutcracker and therefore places the graft under compression. Similarly, during flexion, it relatively unloads the graft. Another concept that's frequently asked is the posterior C1, C2 fixation. Remember that the modified Galley and the Brooks, the older constructs, are good in flexion, but somewhat relatively weak in extension and rotation. The newer constructs, the transarticular screw, provides better flexion, extension, and rotation, but the C1 lateral mass and the C2 pedicle screw provides the best in flexion, extension, and rotation. This construct is the preferred technique for C1, C2 posterior fixation. If we look at the lumbosacral junction, remember that the lumbosacral junction is frequently in shear. When patients stand, they'll place the L5-S1 junction under shear and place the graft under tension. Fusion is best in compression, as is Wolff's law. The reason this is important is in patients with high grade slips, grades 3 and grade 4, when patient stands, the L5 vertebra is in shear and fairly vertical. In these cases, instrumenting the L4 will help provide a more horizontal vertebra and therefore increase fusion rates. So for low-grade slips, fuse the L5-S1. For high-grade slips, extend the fusion up to L4. Another concept is this idea of lumbar distraction. Distraction in the lumbar spine results in flattening of the normal lordotic curve. As a result, you'll have a positive sagittal alignment and flat back syndrome, which is bad and should be avoided. So distraction instrumentation in the lumbar spine, such as Harrington rods, should be avoided whenever possible. Let's cover some high-yield facts. In the basic science for the intervertebral disc, we have the annulus fibrosus, the hard outside covering, and the nucleus pulposus. Remember that the annulus fibrosus has high collagen and low GAG content, whereas the nucleus pulposus has high GAG and low collagen. The importance of that is that the annulus fibrosus is good in tension, while the nucleus pulposus is good in compressibility and under load. Also, the annulus fibrosus is high in type 1 collagen, whereas the nucleus pulposus is high in type 2 collagen. As the disc ages, realize that the water content decreases because the GAG content decreases. Relatively speaking, the proteoglycan and the chondroitin sulfate also decrease. You see a relative increase in the collagen diameter and the keratin sulfate concentrations increase. As a result, remember that chondroitin sulfate decreases with aging discs, while keratin sulfate increases. Let's move on to trauma. The occipital cervical dissociation is fairly rare and is classified by the direction of the head in relationship to the spine. It can be anteriorly, as defined by the Powers ratio, posterior or longitudinal. Fixation for this is the standard of choice, and it's occipital cervical fixation. The C1, C2 is a predominantly ligamentous joint. It has the C1, C2 stability due to the transverse ligament. This sits behind the dens and connects the lateral mass of C1. It serves as the primary ligamentous restraint to abnormal C1, C2 motion. On this lateral radiograph here, you can make a line between the cervical ring of 1 and the anterior part of the dens. You want the relationship to be 3.5 millimeters or less between flexion and extension in adult, and 4 millimeters or less in children. Another radiographic view is the open mouth. In this view, you want to add up the sum of the lateral mass overhang between the ring of C1 and the body of C2. If the sum of those two distances are less than 7 millimeters, it is suggested that the transverse ligament is intact. If it's greater than 7 millimeters, it is disrupted, and if it's ligamentous, then it's typically a fusion. If, however, there is a bony fleck, as the CT axial image shows, then perhaps fixation can be avoided and use of a halo might be an option. If there's late instability, then a C1, C2 fusion should be performed. Odontoid fractures can be defined by the bony amount that is injured. In a type 1, it's an avulsion of the tip. These are stable and can be treated on rigid orthoses. Type 2s are the most common, occurring up to 60% of C2 fractures. These have a high rate of non-union, particularly with posterior displacement. Those that are displaced greater than 5 millimeters have a high rate of non-union. If it's displaced greater than 5 millimeters, then a C1, C2 fixation or an anterior odontoid screw is an option. But in order to use an odontoid screw, you must reduce the fracture. Type 3 extends into the body. These are stable and can be treated with an orthosis. C2 isthmic fractures. Type 1 are vertical, non-displaced without angulation. These are typically stable. Neurologic injury is uncommon. It can be treated in a brace. Type 2 is angulation with translation. In these, some extension, a little bit of traction will reduce the fracture, and immobilization in a brace for 3 months. This should be distinguished from type 2As, which is translation is minimal, but there's quite a bit of angulation. In these cases, the addition of traction can result in more angulation and catastrophic neurologic injury. So the importance here is the compression halo and compression devices to help reduce the fracture and fuse as necessary. Type 3 extends down into the facet joint. This is a vertical fracture line with either a unilateral or bilateral facet dislocation. These have the highest rate of injury of neurologic deficits. These are treated with open reduction and stabilization and extending down to C3 or C4 as necessary. In the subaxial spine, these can be looked at as a variety of different injuries. The jump facets are the most controversial and difficult to manage. Determining between a unilateral and bilateral is important. In the left radiograph, less than 25% displacement is suggestive of a unilateral facet dislocation, whereas with a bilateral, greater than 50% dislocation is common. In these cases, neurologic injury is often associated. In determining an algorithm, it's somewhat controversial, but most agree if there's no neurologic deficit or the deficit is stable, a closed reduction without MRI is an option, provided that the patient is awake and cooperative. If the patient is confused, uncooperative, or alcohol is on board, you must obtain an MRI. If it's difficult to obtain a closed reduction, you must obtain an MRI. Decisions to go to surgery include inability to perform a closed treatment. If the MRI or CT reveals an extruded fragment, then going to the operating room to clear that fragment is imperative, and if there's any evolving neurologic during the closed reduction. Compression fractures. These are typically flexion-based mechanisms with anterior wedging. The spinal canal compromise is uncommon, and a closed treatment and a brace is indicated. Indications for surgery include the posterior ligamentous complex being disrupted. This can be suggested by radiographs that show 3.5 millimeters of translation or greater than 11 degrees of angular deformity. If there's evidence of neurologic injury, then surgery is typically indicated. If there's posterior ligamentous disruption, go posteriorly, restore the posterior tension band. If there's neurologic involvement, then an anterior approach and clearing the canal and adding on a posterior instrumented fusion may be helpful. Burst fractures involve the middle column. It's an axial load. These can involve neurologic disorders, as in that axial CT in the bottom, which shows retropulsion of the bony fragment. In these cases, an anterior approach to clear the canal is important, and add on a posterior instrumented fusion if the ligamentous complex is disrupted as well. Extension injuries are common, particularly in the elderly patients. These can result in a central cord. This occurs when there is pinching between the disco-osteophytic complex anteriorly and the thickened ligamentum flavum posteriorly. There are variable amounts of disruption of the ALL, the disc space, and the posterior ligaments. As we move on to degenerative conditions of the spine, we know that cervical spondylosis can result in a variety of syndromes. They're common radiographically, but they're not always symptomatic. There are often false positive MRI findings and should be correlated with clinical findings. They can result in discogenic neck pain. They can result in nerve root compression and radiculopathy, and spinal cord compression and myelopathy. Congenital stenosis can be defined by Pavlov's or Torg's ratio, which is a relationship between the canal divided by the vertebral body width. A normal ratio is 1.0. If it's less than 0.8, then that's suggestive of congenital stenosis. Using absolute values such as the sagittal diameter gives you a sense of what the space available for the cord is. Relative stenosis is defined as less than 14 millimeters, whereas absolute stenosis is defined as less than 10 millimeters. Typically, the treatment is non-operative, particularly for discogenic neck pain or radiculopathy without weakness. Indications for surgery include myelopathy with progression of motor and gait instability, or radiculopathy with persistent pain or progressive weakness. Discogenic pain for surgery is typically less rewarding and should be reserved and avoided if possible. Your options include anterior approaches and posterior approaches. In the anterior approach, there's anterior cervical discectomy and fusion and anterior cervical corpectomy. Posterior options include laminoforaminotomies, laminectomy and fusion, and laminoplasty. Laminectomy alone has really fallen out of favor and should be avoided. The advantages of anterior approach allows you to address the anterior structures. More importantly, allows you to address any alignment. Patients with kyphosis, neutral alignment, or lordosis can undergo an anterior approach. It allows you the potential for correcting kyphosis. The use of anterior cervical plate has shown to increase fusion rates, particularly in multi-level decompressions and fusions, and it can help protect the strut graft. When performing an anterior cervical discectomy and fusion, there are several structures at risk. The recurrent laryngeal nerve, which is an extension of the vagus, is at risk with lower approaches to the C6-7 and C7-T1 disc space. In meta-analyses between left and right-sided approaches, there appears to be no difference between injury to the recurrent laryngeal nerve. However, the superior laryngeal nerve is at risk for high approaches of disc spaces at C2-3 and C3-4. Also remember that dysphagia risks increase with higher levels of discectomies, increases with the number of disc levels that are performed, and also in older patients. Non-union rates increase with the number of levels addressed. If we talk about posterior approaches, the keyhole laminoforaminotomy is an option if it's single level. If it's a soft disc, that is lateral. Central discs are not able to be addressed by the keyhole laminoforaminotomy. Manipulation of the spinal cord is not an option. As a result, you have to go more lateral, and if you do, you must preserve 50% of the facet joint in order to prevent instability. If you take more than 50% of the facet joint, then fusion must be performed. If you can avoid a fusion, this is a motion-preserving procedure. There are some risks associated with this procedure, including air embolism. Laminectomy and fusion allows you to address multi-levels. It has a lower rate of dysphagia than anterior approaches. However, you must have a lordotic or neutral alignment. It may not allow you to adequately relieve anterior compression as well, since it relies on posterior drift of the spinal cord. Complications include the C5 nerve root palsy. This is thought to be due to the posterior drift of the spinal cord. Laminoplasty has also gained some interest. It allows you to address multi-level stenosis with decreased airway and dysphagia, but it's also a motion-preserving procedure. The biggest disadvantage is that it cannot be performed in kyphotic patients. Patients with kyphotic alignment must require either an anterior approach, or if they're flexible deformity, then they can be a laminectomy and fusion. In addition, post-op neck pain after laminoplasty may be greater than in laminectomy and fusion. The C5 nerve root remains at risk with laminoplasty as it does in laminectomy and fusions. Ossification of the posterior longitudinal ligament. This can result in cervical stenosis. It's more common in Asian population, but it's also seen in non-Asians. Typically, the approach is a posterior approach. There's a high incidence of dural leaks with anterior-based approaches due to the fact that the OPLL can erode into the dura. Rheumatoid arthritis. This is becoming less and less common with new DMARDs medications, but in the patients with rheumatoid arthritis, up to 90% can have cervical spine involvement. The most common involvement is the atlantoaxial subluxation, occurring up to 80% of patients. The importance here is obtaining preoperative radiographs. If patients are undergoing hand surgery or joint reconstructions, they should still have a cervical evaluation. Obtaining flexion extension radiographs on the lateral view can help determine instability at the C1, C2 junction. If we start proximally with the atlantoaxial subluxation, the lateral radiograph, greater than 3.5 millimeters is very common in rheumatoid patients and is suggestive of the transverse ligament disruption. Greater than 7 millimeters implies that the alar ligament and the apical ligaments may be disrupted as well. Looking for distance in the posterior atlanto-dens interval. This is the distance between the back of the dens to the posterior aspect and the anterior aspect of the ring of C1. If there's a relative stenosis, if it's less than 14 millimeters, and absolute stenosis if it's less than 10 millimeters. Indications for surgery include neurologic compromise and instability. Stabilization of C1, C2 is all that is needed. However, if there is superior migration, as the dens starts to migrate up into the foramen magnum, you'll have atlantoaxial invagination. In this case, that's due to bone loss between the occiput and C1 or between the facet joints of C1, C2. In these cases, surgery is indicated if there's neurologic compromise or if the dens migrates up into 5 millimeters or more into the foramen magnum, or the cervical medullary angle, which is defined between the pons and the medulla and the cervical spine, is less than 135 degrees. In these cases, myelopathy can present as well as sudden death. As a result, fixation includes occiput to C2. In these cases, the pannus typically resolves after a solid fusion. If the pannus persists and symptomatically requires resection, then a transoral approach is required. With progression, it goes on to subaxial spine subluxation. This involves 20% of the case and is seen as staircase stepping of the subaxial spine. In these cases, facet joint erosion and erosion in the uncovertebral joint can result in instabilities below the C2. Indications for surgery include neurologic compromise, space available cord less than 14 millimeters, and in these cases extend the fusion down to the lowest level of subluxation, which is frequently T1 or T2. Neurologic impairment can be defined by the Ranawat classification. The most important point to note here is that in grade 3, which is objective weakness, to define patients who are ambulatory, the 3A, versus the non-ambulatory wheelchair-bound rheumatoid patient, which is 3B. While surgery can still be performed in 3B patients, it's important to realize that outcomes and prognosis are less successful in severe Ranawat 3B patients. Ankylosing spondylitis. This radiograph to the right is a classic X-ray of a patient with ankylosing spondylitis. These patients are at high risk for acute fractures. These spines are often fused and act like a long bone, so occult fractures are common, and you should have a high index of suspicion. If these patients present to the emergency room with neck pain, even without a history of trauma, you should institute spine precautions, and advanced imaging should be obtained in the form of CT scan or, if possible, an MRI. On this image to the right, this MRI shows there's edema within the vertebral body. There's a small fracture line that goes through the ALL, through the disc space, and you also look for evidence of epidural hematoma, which can be common in the AS patient. Moving to thoracolumbar trauma. We can base these on mechanism. In the compression fracture, the axis of rotation is at the posterior aspect of the body, and with flexion, you have anterior compression. These are typically stable and have no associated neurologic injury and can be treated in the brace or with observation. If pain persists, then cement augmentation in the form of kyphoplasty is an option. Burst fractures are secondary to the axial compression. The middle column as well as the anterior column is typically involved, and there's retropulsion of the fragment into the spinal canal. These can be associated with neurologic injury. The key to identifying a stable burst is the posterior ligamentous complex. Also be aware of lamina fractures in the back. These can be associated with a nerve root compression and being entrapped within the lamina posteriorly. Surgical indications include evolving neurologic deficits, loss of sagittal alignment, secondary disruption of the posterior ligamentous complex. In these cases, 30 degrees of kyphosis or greater, or retropulsion or greater than 50% or loss of anterior height of 50% suggests that the PLC may be disrupted. The gold standard remains obtaining an MRI to determine the integrity of the PLC. However, if a patient has acceptable alignment and they're neurologically intact, extension bracing is acceptable for the treatment of a stable burst fracture. If you must do surgery, posterior approach is traditionally described, going 3 above and 2 below. Neurologic patients with deficits, secondary retropulsion, requires an anterior decompression. Circumferential anterior posterior fusions might provide you the advantage of short segment constructs. What they may ask is patients with deformity and no neurologic deficits, you can perform a posterior spinal fusion. If there's a neurologic deficit, go anteriorly to clear the canal. Add on posterior instrumentation if the ligamentous complex is disrupted. If they demonstrate a laminar fracture with neurologic, you must go posterior to clear that nerve root and try to repair the dural tear if possible. In flexion distraction, the axis of rotation is moved anteriorly to the ALL. In these cases, a flexion moment results in distraction posteriorly and moves anteriorly. There's usually 3-column involvement. These have also been called lap belt injuries and chance fractures. Remember that in flexion distraction, there's no translation. There's a high association of intra-abdominal injuries, including the ilius, and duodenal injuries due to deceleration. Important to remember because extension bracing may worsen the ilius. In single-level bony fractures, these can be treated with bracing because the bony edges will heal. However, if it's ligamentous, late deformity can occur. Even if you can get the alignment, late traumatic deformity and kyphosis can occur. In these cases, a posterior tension band reconstruction is recommended. In a fracture dislocation, the mechanism is variable. There's a translation and all 3 columns are involved. Unlike the flexion distraction injuries, there's associated translation which results in neurologic injury, and these are highly unstable fracture patterns. This table here describes the 4 fracture patterns. Compression involves the anterior column. The burst involves the anterior and middle column. The key to stability is whether or not the posterior ligamentous complex is intact in a burst fracture. A flexion distraction proceeds from posterior to anterior, whereas a fracture dislocation involves all 3 columns. The T-list classification uses a morphology as also adds in the integrity of the posterior ligamentous complex and the neurologic status. The key of the TLS system, the T-list system, is it helps identify the significance of the posterior longitudinal complex. The spinal cord injury, remember that patients who present with spinal cord injury, you must adhere to the ABCs, airway, breathing, and circulation. Maintain a primary survey and spine precautions. Resuscitate the patient, oxygenate and perfuse the spinal cord. Obtain your radiographs. If you obtain an x-ray, a lateral C-spine x-ray, you must see the C7-T1 junction because 10% of spinal cord injuries can occur at the cervical thoracic junction. Spiral CTs have really replaced radiographs and have provided a full spinal evaluation. Some basic neuroanatomy. Just remember that the central cord syndromes have greater involvement of the upper extremity than lower extremity. This is due to the homunculus and involvement of the uppers greater than lowers. In the anterior cord syndrome, you have loss of motor, pain, and temperature below the level of injury bilaterally. In the Brown's cord, it's ipsilateral motor and contralateral pain and temperature involvement. And in the posterior column, it's loss of vibration and position sense below the level of the injury. If we think about it more in high-yield facts, we know that the most common injury is the central cord. The less common is the posterior cord. Remember that prognosis for ambulation is best with the Brown's cord. It's the worst with the anterior cord. If they give you a mechanism of vascular injury, think anterior cord. If they give you a penetrating injury such as a gunshot wound or stab, think Brown's cord. If they give you hyperextension in the elderly, think about central cord syndrome. If it's upper greater than lower involvement, it's central cord. If it's lower greater than upper involvement, it's anterior cord. Just a statement about neurogenic shock versus spinal shock. Remember that neurogenic shock is hemodynamic instability. This is due to vasodilation, secondary to sympathetic injury and loss and unopposed loss of sympathetic and unopposed vagal tone. In these cases, the vasculature dilates and patients are hypotensive. Because the sympathetics are injured, they're unable to mount tachycardia, and it's hypotension with bradycardia. The treatment includes monitoring, providing fluids, and then vasopressors. This should be distinguished from spinal shock, which is not a hypotension or hemodynamic instability. In spinal shock, this is injury to the spinal cord, and due to metabolic derangement, patients have inability of flow of their spinal column and may have motor and sensory loss. However, this may not be permanent and unable to determine if it's complete or an incomplete until the end of spinal shock. The end of spinal shock can be determined by the return of bulbar cavernosus, which is the lowest reflex arc and occurs after 48 hours. Remember that if it's complete, if there's no motor or sensory level below the injury, and incomplete if there's partial motor or residual sensory. Therefore, a careful neurologic exam should include a rectal exam to look for sacral sparing, which is perianal sensation and retention of perianal sensation. Conus medullaris versus cauda-equina syndrome. Remember that in conus medullaris, this injury occurs at the level of conus, therefore it's at T11, T12, or T12L1. This results in isolated bowel and bladder dysfunction. This is in contradistinction from cauda-equina syndrome, which happens below the conus, and it results from cauda-equina compression. This is typically due to a large herniated disc or tumor or something that causes severe stenosis. In these cases, there's lower extremity deformity, lower extremity dysfunction, as well as bowel and bladder dysfunction. These should be treated urgently or emergently for surgical decompression. Autonomic dysreflexia is due to sympathetic overdrive. This typically occurs in patients who are recovering in rehab. This can present as sudden hypertension, pounding headaches, flushing, profuse sweating, or blurred vision. These are potentially catastrophic hypertensive events. You should search for orthopedic causes, including undiagnosed fractures, obstruction of the urinary catheter, or fecal impaction. The use of high-dose steroids in spinal cord injuries is becoming more controversial. At best, it's considered an option, is no longer recommended or considered a gold standard. Remember that it's not indicated in patients who undergo gunshot wounds to the spine or patients who have peripheral nerve injuries. It's only for spinal cord injuries. So patients with stingers and nerve level injuries are not indicated for high-dose steroids. Just a comment about gunshot wounds to the spine. Remember that steroids are not indicated. The risks of infection outweigh the theoretical benefits. Bracing is usually not necessary unless the projectile involves both pedicles and greater than 50% of the vertebral body. What is often asked is what antibiotics should be used. If the projectile does not enter into the abdominal cavity, then oral antibiotics are sufficient. If it injures a solid organ, such as the liver or the kidney, then oral antibiotics are indicated. Surgery is an option if there is indication for general surgery involvement and debridement of the tract. Removal of the projectile is not necessary if it's embedded within the vertebral body. If there's involvement of the hollow organs, such as the small bowel or large bowel, then IV antibiotics for 10 to 14 days is indicated. Don't forget about the tetanus as well. Surgical indications include abdominal organ injury or deteriorating neurologic status. One way to think about determining when to remove the projectile is best understood of where the projectile is. If it's outside the spinal canal, it can be observed. If it's within the spinal cord, it depends on the level. If the projectile is at T12 or above, this is spinal cord level, so typically we'll observe those, and emergent decompression is not necessary. However, if the projectile is below at L1, then it's controversial, but consideration for surgery is an option. In these cases, this is the conus, and manipulation of the common dural sac can be performed. Thoracic and lumbar degenerative conditions. If a patient presents with back pain, we can create a differential diagnosis. If the back pain is worse with flexion, it's typically discogenic. If it's leg pain predominant, that's worse with flexion. Then usually the disc is pushing on a nerve causing leg pain. It's usually a herniated disc. If patients present with back pain, it's worse with extension. Think about posterior element pathology such as facet arthropathy, spondylolysis, or spondylolisthesis. If it's leg pain predominant, that's worse with extension and better with flexion. Think about neurogenic claudication and classic spinal stenosis. Once you create a differential, you can establish a treatment algorithm. Imaging is not necessary in the early period. Patients who present with less than 6-week history of symptoms can be treated conservatively. If they have persistent symptoms, then start with plain radiographs. There are some caveats, however. If patients have a history of trauma, if there's chronic steroid use, there's increased risk of compression fractures, or history of previous cancer, or other red flag signs, then plain radiographs should be instituted. Start with x-rays, and then move on to MRI. Remember that MRIs need to be correlated with clinical findings. False positive MRIs are common and can occur up to 93% of patients who are greater than 60 years of age. Discogenic back pain is back pain without radicular symptoms. In these cases, start with x-rays and then MRI. In the MRI, you may see decreased signal or on T2 imaging, known as the dark disc, and there also may be something known as a high-intensity zone, which is thought to be an annular tear. Discograms have fallen out of favor. The thought of using a needle for discograms might be that it increases the risk of disc degeneration. In general, for discogenic back pain, the treatment is non-operative. Very rarely is spinal fusion ever considered. This is an MRI, a T2 weighted axial and sagittal image. You can see here this is the high-intensity zone, which is the annular tear, and thought to be fluid within the annulus. When a disc herniation occurs, one thing you want to try to identify is which nerve is being involved. In a common L4, L5 disc herniation, the most common location is posterior laterally. This is because the posterior longitudinal ligament is a relatively stout structure, and the disc herniation usually occurs just lateral to that. When that occurs, the most common nerve is the traversing nerve. So therefore, in an L4, L5 disc herniation, it would affect the L5 root. However, a far lateral herniation will affect the exiting root. So in L4-5 herniation, a far lateral will get the L4 root, and a foraminal herniation will get the exiting root. So posterior lateral will get the 5 root, a far lateral will get the 4 root, and a foraminal stenosis will result in exiting stenosis at the 4 root. Post-op imaging, MRI is your option of modality of choice. If it's a revision or recurrent disc herniation, then an MRI with gadolinium is preferred. In this image here, this is a T1 weighted image. You can identify the laminectomy from the previous surgery. There's dark tissue here. Once you administer GAD, if it lights up, then this is granulation tissue or scar. Disc material is avascular and therefore would remain dark. Spondylolysis and spondylolistheses. Oblique radiographs are able to identify the pars. This is the Scotty dog sign, which is the collar noted here, which is the pars intraarticularis, and it's suggestive of isthmic slip or isthmic pars defect. Remember that the SPECT scan is the most sensitive test for the diagnosis of isthmic spondylolistheses. In an isthmic slip, the gill nodule, which is the fibrocartilaginous reparative process, is the posterior aspect of the frame, and therefore the exiting nerve root is affected. So in an L5-S1 isthmic slip, it would be the L5 exiting root. On this MRI on the right, you can see the L5 root being pinched between the gill nodule and the posterior and the disc anteriorly. Remember, the exiting nerve is affected in an isthmic slip. Iatrogenic causes for spondylolisthesis occur due to removal of the pars. This can be seen here on the schematic, which is connecting the superior articular facet to the inferior articular facet. Other causes for iatrogenic spondylolisthesis include complete removal of 100% of a unilateral joint or greater than 50% of 2 joints. This can occur as you follow nerve root down as you do your foraminotomy. Make sure to preserve the pars and to preserve 50% of the facet joints. With spinal stenosis, that's narrowing the spinal canal, there's 2 different major types of stenosis. There's central stenosis and lateral recess stenosis. Central stenosis typically presents with neurogenic claudication. This is the classic presentation of heaviness or cramping in the calves. Patients prefer a forward flex posture. This opens up the canal. This is also the so-called grocery cart sign, where patients state that when they lean forward on their grocery cart, they can walk as far as they want, and that extension makes their pain worse and flexion makes it better. You have to differentiate this from vascular collocation. Lateral recess stenosis occurs as the nerve starts to exit. This occurs in the entry zone and is secondary to the superior articular process. In this image, cross-sectional anatomic image, you can see the superior articular process causing lateral recess stenosis. In these patients, they present with radicular symptoms from a single nerve root. Treatment remains non-operatively, patient education, activity modification, and anti-inflammatory therapy. Occasionally, corticosteroids in the form of epidural steroids or selective nerve root might provide some relief for the nerve root compression. If you must choose operative options for decompression for laminectomy for central stenosis, if it's lateral recess stenosis, perform a medial facetectomy, identify the nerve root, and remove the superior articular process. Make sure to preserve the pars, and if there is no instability, then fusion is not necessary. If, however, you thin out too much of the pars or you move greater than 50% of bilateral facet joints, then a fusion is typically necessary. Preoperatively, if there's evidence of a spondylolisthesis or scoliosis, then a fusion with or without instrumentation should be considered as well. Therefore, if a patient presents with neurogenic claudication without spondylolisthesis, a decompressive laminectomy is the option of choice. If patients present with neurogenic claudication with a spondylolisthesis, then a decompression along with a fusion with or without instrumentation is necessary. Thoracic disc degeneration is fairly common on MRI, but as far as surgery is relatively uncommon. They make up about 0.2 to 2% of all discectomies. It's slightly male predominant and occurs in about 40 to 60-year-olds. They start to develop disc degeneration. The history and exam is typically pain, radiating symptoms are the most common sign. Spinal compression can also occur. The classic is normal upper extremity involvement with with abnormal lower extremity exam. You might see upper motor neuron signs in the form of Babinski or clonus. If you see a patient with a negative Hoffman and positive clonus, make sure to check for thoracic disc disease and thoracic myelopathy. Start with imaging as you would in the lumbar spine. If patient has radiculopathy only or back pain, then the treatment is non-operative. If they have myelopathy, then a progression of a weakness, then surgery is indicated. In these cases, there's a variety of approaches described, but what is important to understand is that laminectomy alone is the wrong answer. It provides poor results and has a high rate association of paralysis. Spinal infections. These really are a continuum between osteodiscitis to osteovertebral myelitis and epidural abscess. But if we think about them as single entities, then osteodiscitis is typically treated non-operatively. It mostly occurs from pyogenic infections. The symptoms vary based on acuity of the disease. If it's subacute or chronic, frequently the patient may present with just pain. Very uncommonly, they will have fever, perhaps less than 50% of the time. And abscesses are uncommon as well. Laboratory results with SED rate and CRP are frequently elevated, but in chronic cases, the white count can be normal. Blood cultures are typically negative and are frequently only positive in 25% of cases. Radiographs can be normal or lag behind clinical symptoms. The most earliest sign is typically disc space narrowing, and on this tomogram on the right, you'll see loss of the end plate. This can lag behind up to 2 to 8 weeks of clinical symptoms. CT scan can help assist in identifying the end plates, as well as look for cystic changes or gas within the soft tissue. Bone scan can help because 3 to 5% of patients present with multifocal infections. It also allows for whole body imaging. The imaging modality of choice remains the MRI. On T1, there's decreased signal with indistinct margin of the disc space and the end plate. MRI with gadolinium helps demonstrate enhancement on T1 weighted image with increased inflammatory vascularization. T2 weighted images demonstrate hyperintensity at the involved levels. Empirical treatment includes parenteral antibiotics. 4 to 6 weeks of IV antibiotics is recommended. There's a higher failure rate with less than 4 weeks of treatment. Oral antibiotics can then be transitioned after 6 weeks of IV antibiotics. Obtain a SED rate and CRP. This allows you to follow your treatment. If the SED rate and CRP continue to improve, this is indicated that the treatment is resolving. If, however, the SED rate and CRP starts to increase again, consider a repeat biopsy or obtaining an open biopsy to better define if there's a secondary infection or superinfection. Orthosis is usually not required. It is a component of osteodiscitis in the peds patient, but in adults, it's not necessary. It may be an option for pain control. Make sure to address comorbidities such as hypoxia, metabolic deficiencies, diabetic and nutritional status. Also make sure to search for other underlying infections. Indications for surgery. If you're unable to obtain a diagnosis on biopsy or the biopsy is negative, or it's unsafe to obtain a percutaneous biopsy, then consider an open biopsy. If there's a clinically significant abscess, these are typically not well addressed with IV antibiotics and require drainage. If they undergo a medical treatment for 6 weeks with persistent symptoms or elevated SED rate that continues to rise, consider surgical debridement. And certainly if there's neurologic deficit or deformity or bony destruction resulting in malalignment or loss of alignment, then consider surgical decompression and stabilization. Tuberculosis spondylitis, this should be differentiated from pyogenic infections. The pathologic changes usually take a little longer to develop. The disc space is relatively resistant. In pyogenic infections, they start at the disc space. In tuberculosis infections, they preserve the disc space. There's usually more extensive bone loss. There's usually a larger paraspinous abscess, and frequently these result in greater deformity than pyogenic infections. The management of tuberculosis spondylitis involves debridement, but also more importantly, pyogenic and tuberculin medications, usually triple or 4 anti-TB medication is important to use in addition to surgical debridement. Indications for surgery are the same for pyogenic infections. If you're unable to maintain the diagnosis or they have deformity or neurologic compromise. Epidural abscess, these patients present more systemically ill than osteomyelitis patients. They often present with fever, chills, hypotension. These patients are systemically ill. This MRI on the right shows a T1 GAD MRI weighted image that shows a phlegmon with a central nidus. It's important that these patients are surgical. Medical management is rarely indicated for epidural abscess. Some considerations then for osteomyelitis. If you're going to do surgery, consider an anterior approach. This is because the pathology is from the disc space, so debridement of the disc is better accessed from the anterior approach, particularly in the cervical and thoracic spine. Rarely is isolated laminectomy an option. This might be an option in the lumbar spine, but if you perform that, you must perform a discectomy from a posterior approach in order to clear the osteodiscitis. Epidural abscess, the approach is based on the location. The vast majority of abscess are in the posterior aspect of the canal. If that's the case, then a posterior laminectomy alone is an option. If it's in the cervical and thoracic spine, then you must include stabilization along with the laminectomy. Make sure to preserve the facet joints. If there's an anterior epidural abscess in the canal, or if there is osteodiscitis or vertebral body involvement as well, then consider an anterior approach to address that component. Post-op surgical infections. Remember that preoperative antibiotics can reduce the infection rate by 60%. A single parenteral dose 30 to 60 minutes prior to incision can reduce that infection rate. Consider redosing in spine cases for prolonged surgical procedures greater than 4 hours, substantial blood loss greater than 400 cc's, or gross contamination. Continued use of antibiotics past 48 hours is not supported in the literature, and the use of topical vancomycin powder appears to have some benefit. Treatment protocols include irrigation debridement, hold perioperative antibiotics until after intraoperative cultures have been obtained. In regards to the instrumentation, if the instrumentation is well fixed, you can retain the implants. In regards to the bone graft, if the bone graft is loose, it should be removed. If it's vascularized and incorporated, it can be retained. Adult deformity. It's important to understand sagittal alignment. In this image on the left, the plumb line of C7 falls from the middle of the body of C7. It crosses the thoracolumbar junction at T12L1 and falls at the posterior corner of L5S1. If this falls anteriorly, that's considered a positive sagittal balance. Neutral is if it falls at the junction of L5S1 or 5 centimeters in front of it, and negative is if it falls behind the L5S1 junction. In this standing scoliosis radiograph, we can see this patient has a sagittal plumb line that is 15 centimeters positive, so this would be a positive sagittal balance. Spinal pelvic alignment. It's important to identify the relationship between the pelvis and the spine. The number that is most oftenly quoted now is the pelvic incidence. This is an anatomic constant. It's defined from the center of the femoral head taken to the middle of the sacrum and a perpendicular down. This is related to the lumbar lordosis by 10 degrees. The greater the pelvic incidence, the larger the lumbar lordosis that you need in order to maintain sagittal alignment. Remember also that the pelvic incidence is equal to the sacral slope and the pelvic tilt. The larger the PI, the more horizontal sacrum, and the greater the lumbar lordosis. Let's cover some high-yield facts just to finish up. When looking at the applied anatomy for bone grafts harvest, remember that anterior bone grafts place the lateral femoral cutaneous nerve at risk. This sits 1 to 2 centimeters from the anterior superior iliac spine. An injury to that will result in anterior thigh numbness. In a posterior approach for bone graft, the superior cluneal nerve is at risk. This lies 8 centimeters lateral to the PSIS, the posterior superior iliac spine, and can result in butt numbness or buttock numbness. The superior gluteal artery is also at risk at the posterior approach to the iliac crest. As far as the vertebral artery and the cervical spine, remember that the vertebral artery sits on the superior aspect of the ring of C1 in the vertebral sulcus. Therefore, dissection of the ring of C1 should stay within 10 millimeters of the midline on the superior aspect and 15 millimeters on the posterior aspect of C1 in order to prevent or reduce the risk of vertebral artery injury. The greater occipital nerve, or C2 nerve, is purely a sensory nerve. It exits between the C1-C2 joint and innervates the posterior aspect of the skull. Remember that it's at risk for C1-C2 transarticular screw fixation. Also, in rheumatoid patients who have C1-C2 erosion and settling, they can get a C2 greater occipital nerve neuralgia and result in posterior cervical pain. Remember that in anterior approaches, that the preganglionic sympathetic chain is at risk, and if it's injured where it sits on the anterior aspect of the longus colli, it can result in a Horner syndrome. This can result in ptosis, which is drooping of the eyelid, miosis, constriction of the pupil, and anhidrosis on the same side of the approach. So it's ptosis, meiosis, and anhidrosis ipsilateral to the side of the injury. Remember that cervical approaches the high cervical disc at C2-3. It places the superior laryngeal nerve at risk. This is important in patients who are singers because they need to perform high phonation, and the superior laryngeal nerve performs high phonation. It's at risk with standard approaches, therefore a modified submandibular or anterior retropharyngeal approach is preferred. The superior laryngeal nerve is at risk at C2-3 and upper cervical disc herniations. Differentiating between superior laryngeal nerve and recurrent laryngeal nerves, remember that the superior laryngeal nerve has high phonation, but it does not innervate the vocal cord, whereas the recurrent laryngeal nerve results in vocal cord paralysis on the side of the injury. It can result in hoarseness, aspiration. The phonation can be partially compensated for. So recurrent laryngeal nerve results in vocal cord paralysis or adduction of the vocal cord on the side of the approach. Superior laryngeal nerve does not result in any vocal cord paralysis. In the lumbar spine, a medial branch block, this is the nerve that innervates the facet joints. So for patients with facetogenic pain, when they undergo a facet ablation, it is the medial branch of the dorsal primary rami of the sinovertebral nerve that is being denervated. They may call it the medial branch block. They may call it the sinovertebral nerve block. Both terms are acceptable. Intradiscal pressure increases from a patient laying supine to standing. The highest pressure is when sitting and leaning forward. This is the main reason that discogenic pain is worse with sitting, and also why patients with disc herniations prefer to stand, and that sitting aggravates the leg symptoms due to increased discal pressure. Remember that during approaches to the lumbar spine, anterior approaches can place the nerves at risk. In particular, remember that sexual dysfunction after anterior lumbar surgery has been well described. In the case of injury, it's from retrograde ejaculation due to sympathetic injury. This is the point and shoot. Remember that point is parasympathetic. It's erectile dysfunction. Shoot is sympathetics. It's retrograde ejaculation. Therefore, injury is due to the sympathetic chain, whereas dysfunction, erectile dysfunction, is not due to your approach. That's due to parasympathetics deep in the pelvis. The superior hypogastric sympathetic plexus lies on the anterior aspect of the L4, L5 disc and at the L5, S1 level, and is at risk for anterior approaches. Remember that a misplaced SI screw that is anterior to the SI joint places the L5 nerve at risk. This runs over the sacral ala and is at risk for an anterior placed SI screw. This is a classic MRI of a patient with a syrinx. On the left is a T1 weighted image. Remember that syrinx can occur late in spinal cord injury patients. They can cause scoliosis in patients who have a spinal cord injury, and they may present as Charcot joints of the shoulder or the hip. Also think about obtaining an MRI in patients who have increased spasticity or neurologic changes who were previously neurologically stable in the spinal cord injury. They may be presenting with a spinal cord and a syrinx in their spinal cord. All right, that finishes up our spine section. Good luck on your exam.